Okay, so today we're going to be learning about the different dyslipidemias that a patient might present with. Dyslipidemias are, as they sound like, disorders in the blood where patients have too much or too little of one lipid or another. So we're going to break it down into several different categories. The first is the high cholesterol disorders. And in this situation, patients have too much LDL. So there's two real key different disorders here that we need to be familiar with. The first is familial hypercholesterolemia, and the second is a defect in ApoB100. Both of these are inherited disorders, and they actually present pretty similarly clinically, but they have some different causes, so we're going to define those different causes here. In familial hypercholesterolemia, patients actually have a decreased production of their LDL receptor, so circulating LDL in the blood with normal ApoB100 has no receptor to bind to, so it's actually not able to get taken up out of blood, and therefore the LDL levels are going to build up, causing the pathology that we see in these patients. Alternatively, we can go over to ApoB100, and in this defect it's quite a different situation, even though it presents similarly. The patients have decreased ApoB100 on their actual LDL particles, so the LDL doesn't get recognized by the receptor, and then it doesn't get taken up. So ultimately the effect is similar, even though the two are mechanistically different. They present similarly clinically, as I've said, with things like corneal arcus. That's a gray ring in the patient's eyes. Patients may have tendon xanthomas. They may have premature atherosclerosis. They also may have things like xanthelasmas, which is a pretty interesting finding where they'll have cholesterol deposits around the eye, and that can be a key finding in diagnosing an LDL disorder. So like I said, the LDL's increased. Triglyceride levels, though, are normal, and that's really the key distinction between this and other groups that we're going to visit later on in this lecture. I just want to touch back on familial hypercholesterolemia for a moment. You could have two different types. It's an autosomal dominant disorder, but if the patient is a heterozygote, their cholesterol levels tend to be around 300. Alternatively, if they're homozygous for the disorder, their cholesterol levels are going to be subsequently higher. So that's a key distinction, and cholesterol LDL levels can kind of help you decide whether or not the patient has heterozygous disorder or homozygous. Now, to treat all of the increased LDL disorders, we're going to use statins, and we're also going to use the drug ezetimibe. Ezetimibe, I apologize. And those are really the key things that you need to know about increased LDL disorders. So now we're going to go to another category of dyslipidemias. And here we're going to be touching on disorders that have an increase in both LDL and an increase in triglycerides. So these, another way that you could say them, are mixed disorders. And these are actually fairly common in the population, particularly familial combined hyperlipidemia. But they have some different manifestations that really help us distinguish between the two when we're taking step 1 or our medical school exams or when we're visiting patients in the clinic. So it's pretty important to be able to note the distinctions. So the levels are going to be dramatically increased in the first disorder, which is dysbeta-lipoproteinemia. This is an autosomal recessive disorder in which patients have a normal HDL. And that's a pretty key finding because the HDL levels are going to be different in familial combined. So, like I said, they're going to have normal HDL. They're going to have a deficiency of ApoE, which is one of those important apolipoproteins that we're going to make sure we know. And in this disorder, the liver uptake of chylomicron remnants and intermediate lipoprotein is actually deficient. So that's what causes a lot of the pathology. So some symptoms that are key findings are tuberoruptive xanthomas, and these are going to be xanthomas that appear on the patient's elbows, on the patient's knees, and on the patient's butt. So if you see any thing like that in a stem or on the wards, then that needs to make you think of dysbeta-lipoproteinemia. Patients may also have palmar xanthomas, which is exactly what it sounds like, and they also have an increased risk for coronary artery disease and peripheral vascular disease. So that's why we need to worry about it and consider treating these patients. Now, the alternative mixed disorder is our familial combined hyperlipidemia. And in this situation, the levels, they're not increased as much as they were in dysbeta-lipoproteinemia, but in some cases they can still be increased to enough degree that it causes some pathology. So I had to switch over here. My video timed out. But as we see, the HDL is decreased, the cholesterol and triglycerides climb around puberty, and metabolic syndrome association is pretty key here. Patients present with premature coronary artery disease, but they don't have xanthomas, and they can get pretty high cholesterols. And as you saw there, we treat these disorders with niacin because that will increase the HDL levels, which, as we heard in familial combined hyperlipidemia, the HDL levels are decreased. So we want to drive those back up. Now we're going to focus on the increased triglyceride levels only. And we've got two more disorders here. So I know it sounds like a lot, but once you lay it all out, it's not too bad. Here we have a disorder of either increased VLDL or an increased disorder of chylomicrons. So first we're going to touch on the chylomicron disorder. And once again, within this subclassification, we actually have even two more. But the key thing is that they're going to present very similarly clinically, so you don't need to worry too much about the distinction. But some of the key differences may help you when you're taking step one. In familial LPL deficiency, patients have a decreased lipoprotein lipase activity. They actually don't produce enough of that enzyme. It's an autosomal recessive disorder. That's really the key things you need to know. Alternatively, patients could have a familial ApoC2 defect. And in this disorder, it's not that they have an insufficient amount of the lipoprotein lipase enzyme. They have an insufficient amount of ApoC2, and that results in decreased activation of the lipoprotein lipase enzyme. So as you can imagine, the effects are relatively similar, and we're going to look at some of those effects here in just a moment. This is also an autosomal recessive disorder, and that's an important thing to remember when you're studying for step one. Some of the key findings that we tend to see are things like lipemia retinalis. Children often present with this disorder with acute episodes of pancreatitis, and that's a really common way that stems tend to be presented for these disorders, so you really want to pay attention to acute pancreatitis in children. Hepatosplenomegaly is also common in these patients, and really the key distinguishing factor here between this and VLDL disorders is that serum in patients that have chylomicron disorders is clear after you refrigerate it. So now we're going to move over. We're going to take a quick look at our increased disorders of VLDL, and I just need to move over to a new sheet of paper so that I can continue drawing with plenty of room. And here we've only got one disorder to really remember, so that's a good thing. Makes it a lot easier for us. Here the main disorder of increased VLDL is familial hypertriglyceridemia. And what we have here is an overproduction of VLDL particles in the liver. As you know, the liver is the site where VLDL gets made, and these patients just have too much of it. So problems don't arise in childhood like they did with chylomicron disorders. Rather, they arise when the patient reaches adulthood. It's an autosomal dominant disorder, and if we remember over to the chylomicron disorders, both of those were autosomal recessive. These patients will present with an increased risk for coronary artery disease and peripheral vascular disease, and kind of important to note that they will have an decreased level of HDL. And the key distinguishment as well is that serum in patients that have increased VLDL levels will be turbid, so it'll be cloudy after you refrigerate it. And if you remember, we said that serum is clear in chylomicron disorders after refrigeration. So all of these disorders have some common findings, and we're just going to look at those real quickly. I've combined them onto this one page so we can see it more easily here. We're going to treat it with fibrates. That's the main drugs that we're going to use to drive down our triglyceride levels. And then all of these patients that have increased triglyceride levels tend to develop eruptive xanthomas all over. So here we have a full view of all of the dyslipidemia.